benefit strategy needs to change with your business strategy. It has to be intertwined with it. I tell people this all the time. It's like you set up, it's not a set it and forget it and just keep renewing every year and take the whatever increase was and move on. It's not a cost of doing business. It's an investment in the business to help it strategically accomplish the bigger goal. And so understanding what things are going on behind the scenes so you know how to make it effective is going to change. All right, here we are. Chris and Jake, show number 2. Good to be here. We're still coming up with a name. We have our own personal brands. We have our passions, which are aligned. And I think that's what makes this show different and unique, is we're just trying to pull the curtain back and put out there all the things we've been talking about on the phone anyway, just sharing it with more people.
Yeah. So, I mean, that's the goal, is create a community of like-minded people that are looking to solve the problem of rising health insurance costs that's plaguing our society. And, when I say society, it's really happening through employers. Majority of people in America are buying their health insurance. About 60% of the insured market is people that are buying health insurance through an employer. And so really the onus is on employers, because think about it, employees don't get to make benefits plan decisions the way the plans are designed. It's really educating employers on what they can be doing to fix health insurance for their companies and their employees. And by doing that, they're helping society. The more employers that do it.
Yeah. I mean, it's fascinating how this industry really is super new. Like we talked about the last show, less than 100 years old, but yet now, when you switch jobs or look for a new job, a lot of times the discussion is around what's my total compensation? What are the benefits? And you really have no say, and oftentimes don't have a lot of clarity into what your benefits are going to give you. I just went through that process, right? I just switched companies, went through my open enrollment. Took me a couple hours, honestly, because I was comparing what my wife has. She's a teacher, part-time teacher, has a little bit different options than a full-time teacher. But you would think with the scale and size they have that they would be, super competitive. But there were things that I found and holes that I found, like, all right, I better jump on mine versus should we stay here? And it was a very intense procedure to go through for me, because I was thinking, I know all this stuff. Yet it was still a lot to kind of digest. So it's the normal person's going through this all the time. It's crazy.
Yeah. I think it's real interesting. There are surveys out there that ask people how long it takes them, or how much time they spend making benefits decisions. And the surveys show that people will spend more time researching the difference in iPhones or a difference in television. Partly, I think it has to do with how complicated benefits are and how much information is actually available. And a lot of employees feel like, okay, I've got these 2 or 3 plan options. I don't really understand how they work. I'm just going to make an educated guess based on what I think I'm going to spend on healthcare and what the employer is charging me. But you think about those other things that Americans are buying every day, they've got a lot more information available to them. They can read reviews, they can read technical specs. There are things that we use on a daily basis, and they really have a better understanding of what it is they're buying. But I mean, health insurance is super expensive, whether you're a company or an individual. And when you look at what people pay for health insurance, it's often more expensive than what they're paying for, especially if you're covering a family and you're working for a mid-sized employer. It's definitely more than your car payment, and it probably rivals your house payment. And that's just for insurance. That's not even when you need to go get healthcare. And so it's a systemic problem in our society that we talked about it on the last show, that you think about how much money people spend for health insurance. It's money that doesn't go into 401k. It doesn't go into kids' college educations. It's not saving for a new house or a car or all the things the American dream is built on. And it's literally sucking out the lifeblood of the American dream from our society. And that's where I think the big opportunity, based on our experience, is helping employers solve that problem for their employees. And it also benefits companies at the same time.
Yeah, I've been meeting with a few different groups, and the trend I see, and this is a lot of contractors and people in construction, the trend I see is a lot of people are just opting out. They're not doing it. Either they hopefully have some coverage somewhere, or they're just going without and hoping that everything will work its way out if something were to happen to them, and which is scary. When you think about what that could mean for their family if something did happen. So the other trend I see is people just kind of follow, like they set whatever plan they're picked initially, and they just let it continue on, and maybe their family has changed in a lot of ways, and maybe there's different things they know that are coming up, but they don't look at the plan to say, is this the right one for me for this next year? And maybe they kind of think, well, I don't have any control or say, and I don't really know what questions to ask, so they just kind of stay quiet. And I that to me is a thing I'd love to work towards fixing that problem, so that people feel more comfortable, know where to get information. It's not just an 800 number. Really navigating the decision during open enrollment, which will help them know how to make better decisions throughout the year to benefit their family.
Yeah, and I'm sure we'll get into this, but uh, a big focus of our practice is helping employers design a plan that makes it super easy for employees to make a decision, because you have to make it it's a black and white decision that this plan, or you give them an option of plans, but they're able to quickly and easily look at this in layman's terms and understand the cost differences and the benefit differences. And if you're able to make the differences so dramatic, it makes it easy for employees to make a decision. That's really what this comes down to, is how do you simplify the complex to a level that an average day-to-day working American can understand? Because when you start showing a $1,000 deductible versus a $2,000 deductible and a $20 copay versus a $30 copay, people get lost in those machinations, if you will, of how do I make sense of that? And there's a way to design those plans, and which I'm sure we'll get into at some point, how to make it so stupid easy. The keep it simple method, right? How, how to make a decision that's just easy to make and it's easy to understand is really the goal behind a lot of these benefit plans.
And I oftentimes at enrollment meetings, I notice there'll be somebody in the group, some employee that has a little bit more understanding. Maybe they just did some research, or they've been around benefits longer, and they'll be the ones that kind of people go to and they listen to, and they maybe are not giving good advice sometimes, but there's
Yeah.
trust there. So they kind of follow along in that mentality of, well, they're doing it, it makes sense for me. And then they try to remember what they were told and then go home and tell their spouse, and hopefully it was the right choice. But it's a very complicated decision, and it's an expensive one, and yet we kind of don't put any effort in. So that's probably a whole other
Yeah.
show. I think it's really interesting, and it's a smaller problem in my previous 401k world, where people are like, what investment do I pick? And this is a much bigger thing, because you're actually going to be using this in a lot sooner time than you are, your retirement account. So it's a
Let's do a show on that. Let's do one where we break down how to design a plan to make it super easy for people to make a decision, and how to drive cost savings for an employer and an employee at the same time. I think that's super valuable content that many people around the country can use, because there are options out there.
Yeah. But today we got I think a great topic, one that's really relevant, that I know anyone listening, if you haven't heard this question about GLP-1's and what is going on with some of these pharmacy benefits and the drugs that people are using to reduce obesity and other health effects, it's a big deal right now, and it has kind of came really quick. It's only been a very short time, and now this is impacting a lot of employers. You're seeing it with employers when they're looking at the renewals. I'm starting to have those conversations when they're looking at their pharmacy benefit and their costs that came through that are, increasing the premium. So maybe you want to start with a quote you had. I think it ties in well with kind of this whole topic.
Yeah, it's an oldie but a goodie, and I think it really pertains to what we're seeing in multiple facets of our society, but specifically in healthcare and health insurance. And it's one of my favorite quotes. It's Einstein's definition of insanity, which is doing the same thing but expecting a different result. And we see that a lot in our industry, and as we work with employers at different stages and phases of their company. Oftentimes, I'll get referred to somebody right as they get a big renewal, and quite frankly, if you're already 45 days out from your renewal, that's probably the worst time to make a drastic change, unless you absolutely have to. And you oftentimes hear an employer say, well, we're just going to renew with what we've got. We'll kick it down and address it next year.
I've heard that a lot lately.
Yeah, you hear that a lot. And for some employers, they really do want to tackle the issue. And you can get through that renewal, and the best time to start that strategic planning to fix the problem is immediately after you renew, because all the data is fresh. So you've got recent data, and you have all of the the pain associated with taking a sizable increase, and there's inertia to want to solve the problem at that point. And so that's really where an advisor would be able to come in and put together a strategic roadmap using your data to say, this is what the data is suggesting. Here are the ways that we would recommend that you design that plan. And then you set a timeline to enact it. So you're taking more of a strategic approach versus what you're doing at renewal is more of a tactical approach, meaning, okay, I've got these handful of quotes from these carriers. I only have 45 to 60 days to make a decision. You're looking at the spreadsheet at that point, which spreadsheeting something is more of a tactical decision. I've got these options. Which are the ones going to be the best result for right now? Versus when you do it outside of a renewal, the strategic approach is, let's think about 3 years from now. Like, where are we trying to get? What's the desired outcome? And what are the steps? Because there's usually not just one step. It's probably 5 to 7 steps that have to be taken to really get to the desired end state, if you will. And an advisor, a good advisor, is going to say, these are the steps you take in year 1. Here's how you modify the plan in year 2, in year 3. And then at that point, it becomes more of an active management by your advisor, consultant, broker, whatever you want to call us, to use the data to get actionable insight and to drive the strategy. So it's a living, breathing, evolving strategy based on the population that you have and the conditions and cost drivers that you see in a particular year or that you can project are going to happen in the next year. A good one is, we're going to talk about it today with GLP-1's, the occurrence of diabetes, obesity. Maybe it's cancer that's a big cost driver. Maybe it's other medications that are happening inside of a plan. How do you design a strategy around that to continue offering the same benefit to the employees, but you're managing the cost? And I think one thing, and not to get on a rant here, because you know how I am, Jake, I'll go on rants, but I think this is really important for employers to know. Your health plan is just like a division in your business. We talked about in the last show. But what I mean, I'll go in a little bit deeper detail here. Your health plan is a division of your company. It has its own profit and loss statement, its own income statement, and has its own balance sheet. And when you're in a traditional fully insured plan, the carrier sets the budget and you fund the budget with your premiums every month, every year, and the carrier is managing the expense side. And we've identified in prior episodes and a lot of the content I create is how carriers don't have the same interest. They're not trying to manage costs the same way an employer is. Oftentimes they're managing the cost of that budget, the cost of the claims that go through the plan in a way to maximize their profit and drive higher costs, because the higher more cost there is in the plan, the more ability through some of their channels to profit through their subsidiaries. And at the end of the year, what happens is that carrier is going to come back and say, well, we spent over the budget. Your loss ratio is high. Therefore, employer, we've got to raise your premiums to offset those rising costs. But they're not showing in a transparent way all the other ways that they're making money. And so when you think about from a profit and loss standpoint, most business owners, CFOs, they look at it and say, okay, we want more transparency of where our money's being spent. And when you think about just from a profit and loss, and I mentioned the balance sheet, these plans that we design, when they run well, they run under budget, which means there's income left over at the end of the year, which remains on the company's balance sheet as an asset. When you're fully insured, there's no money flowing back to your balance sheet in the form of cash. And so when you think about a health insurance plan, I talk about strategy, designing a plan that's going to return capital back to the business, and that capital is going to continue to grow over multiple years to where they've now got a war chest of money on their balance sheet to create sustainability of the plan. So it's taking a totally different approach to the way health insurance is designed, to where it becomes an asset to the company. Not just, employers talk about our employees are our biggest asset. Okay, that's great. How are we going to pay for them? How are we going to pay for their health care? When these two different plan structures, they're diametrically opposed to each other. They're completely different. And I think our industry has done a pretty poor job. Not everybody, because I don't want to paint everybody with a broad brush, but just generally speaking, I think from my experience and conversations I've had with employers that are with brokerages all over the country, big and small, we make it more complicated than we have to. It confuses employers. And in that confusion, there's a perceived higher risk. And they're steered away from it. And so, I have different theories on why. I think some brokers aren't as well versed in how to do these plans, and so they sell against it. But they talk about it, and that way, when a broker like you or me walks into that employer and we start talking about it, they'll say, "Oh, well, we've already looked at that before. It doesn't make any sense." The brokers essentially CYA'd. They're covering their backside so that somebody doesn't have the ability to try to steal their business, take their client. And so, we see that dynamic way too often,
Yeah,
way too
it goes
often.
against each other, right? Like you said, you're building up the assets for the company by doing this in a different way versus that's the goal of the insurance company when you go fully insured. They're trying to do the same to build up their cash and their profits. That's the point of the business, right? And so
Yeah.
when those are going head to head, it doesn't really make a lot of sense. And I think the easiest analogy for someone that maybe hasn't dug into this very deep yet is I, I love eating out because it's like saves me time, but I know it's unhealthy and it's expensive. So there's like downsides, but there's upsides. So it's the same thing fully insured. Yeah, it's easier, it's less work, it's easier for you, it's easier for the broker, it costs more. It seems like you're just buying a big package, but are you getting the result you want? Are you getting the good care that you want? And is there a little bit of work up front that you could put in with you and your consultant or advisor that could put you on a better path? And there are shortcuts and I think ways to put together a benefit plan that would get you, all of those things you want at a reduced cost, and it doesn't necessarily have to be, this huge heavy lift. And there's different biases towards, when I switch out of fully insured or not, and should I, and just the fear. And it goes back to, I think this has been on my mind a lot, just the whole Alex, you follow Alex Ramosi and his value equation, right? It's like, what's the dream benefit? What's the dream outcome? What do you want? Unlimited, great free healthcare, right? Everybody wants to have healthcare, that they're going to want it at a certain point in their life, but do they perceive they can get it, right? And I think that's
Mhm.
where we kind of limit ourselves. But then on the bottom of the equation is the time that's going to take and the effort it's going to take. And I think
Yeah.
that's where you're going to get different opinions thrown at you. And depending on where you're getting information and where you really get your introduction to how a health insurance plan really works versus how the healthcare system works, can kind of leave you in a bad spot longer than maybe you should. And that's just unfortunate. And I think that's goes back to, it's easier. Brokers make more money that way, and it
Yeah.
overall seems like a better fit. So you can focus on the business, but eventually you're going to want to explore the other options. And that's what I think we want to dig
Yeah.
into. And what are the different nuances to it? And a huge one right now, if you're not clear in a fully insured plan, what your employees are buying from a pharmacy side of things, which is probably gone up, you're going to have a renewal that went up this year, and you're like, I don't know why. You can't see why. And those that can do something about it. And that doesn't mean take it away. That means figure out how you're going to manage it better.
Yeah. I think that's a really good point, and probably a good segue into the topic today of GLP-1s. Before we get into that, though, I wanted to just hit on real quick a news story from the Wall Street Journal that was published a few days ago, titled "Employers Get Pressure to Pay for Drugs Like Wegovy." So Wegovy is a weight loss version of a GLP-1. It's basically it's the same thing as Ozempic. So it's a weight loss FDA approved version of Ozempic. There's another competing product called Zepbound, which is tirzepatide, which is the same drug as Mounjaro. And what was interesting about this particular article, and this is what's important for employers, you're probably hearing something from your employees about wanting to cover drugs for weight loss. These drugs have been used to treat diabetes. They've had great results of lowering folks' blood sugar,
I
insulin.
mean, it's a hormone, right? It's a hormone that your body, does different things to it as far as regulating the sugar. It's was used, like you said, originally diabetes, and then we realized there's other benefits, which goes down this whole path of, is it just to lose weight, or are there other things when that happens are also positive? And that's where this gray area as an employer, is this covered or not?
Yeah, this article is particularly interesting to me, and about the Wall Street Journal doesn't probably the best job covering what's happening in the health insurance and healthcare industries. And this article is really geared towards larger employers. It's the take of a larger employer, But the reason why, if you're a small or mid-sized business, the reason why it's important for you to pay attention to this sort of thing, because what large employers are doing trickles down stream to small and mid-sized employers, either directly or indirectly. And I'll give you the example. Most of the companies that we work with, when they're trying to hire employees from other companies, they're typically poaching talent from large national employers, maybe they're Fortune 500 companies, and they're making comparisons and benefits to, well, my current employer. I have a client that's in oil and gas, and they hire from Schlumberger and Halliburton, and so they're having to have those benefits compared to those really large companies. Well, oftentimes it doesn't match, and so that's creating a friction point in the hiring process. And so whatever the larger employers are doing, you're having to compete against that, and there's also pressure for you to try to match it. And from a budgetary standpoint, it's important to understand what's happening across the spectrum. And so what's interesting about this particular article is it's talking about the tactics that drug makers, big pharma, is using to try to push their drugs into employer plans. And you think about how drugs have typically been advertised or marketed. It's television, and then they're using sales reps, pharmaceutical sales reps, to go in and pressure doctors to prescribe their medications. Well, now they're taking it because they know who the payers of these medications are. Ultimately, at the end of the day, whether you're fully insured or whether you're self-funded, the true payer of healthcare is employers. That's 60% of the market, employer paid, employer sponsored healthcare. And so the cost is split between employers and what employees are paying. And so they're taking a direct to employer approach here. Let me back up real quick when we talked about the way.
Right? I mean, you think about it, that's who's buying the drugs or spending the most money on the drugs.
Yeah, they're spending the most money. When you look at the way drugs have, particularly the GLP-1s, have been advertised to direct to consumers. By the way, United States and New Zealand are the only countries that allow direct to consumer advertising on television. I think that's important to note. And the biggest market for GLP-1s is the United States. So when you look back 2 or 3 years ago at advertisements for Ozempic, you got the guy who's working on his car, grilling hamburgers, doing a little cheesy workout or whatnot. And at the end of that commercial, it'll say something to the effect of, people who take Ozempic can lose up to 15% of their body weight. And so then you started seeing people taking it for diabetes, having good weight loss, but then you saw people wanting to take it for specifically weight loss. And then that's what caused, and then ultimately what happened is insurance companies weren't approving it for weight loss because it was indicated for diabetes only. And all they've done is they've created a separate brand name for these drugs. So Ozempic is for diabetes. Um, um, I'm having a brain fart here. Wegovy. Wegovy is Ozempic, just under a different brand name. It's the exact same ingredient, main ingredient. It's just branded and approved for weight loss. And then you see Mounjaro, which is for diabetes, and then you see Zepbound, which is the exact same drug, tirzepatide. It's approved for weight loss, and it creates this issue where employers don't cover it for weight loss; they will cover it for diabetes. The drugs are pretty expensive. On average, it's about $1,000 a month, depending on the dose and the specific drug that you're taking. But needless to say, this article is specifically talking about they're taking a third channel of approach to get this approved by employers. Instead of just advertising to consumers start asking their employers to cover it. Advertising direct to doctors through drug reps to prescribe it, you now need somebody to pay for it. So let's go directly to the horse's mouth, the people that design the plans, that pay for the healthcare. Let's convince them why they need to do it. And so in this particular article, it's walking through the case study that Eli Lilly and Novo Nordisk are using to engage employers directly. They're explaining the health benefits of weight loss and how it can have downstream impact on the healthiness of their employees. I don't disagree that if you've got obese employees, they're going to have other health conditions, high cholesterol, high blood pressure. They're maybe at risk for developing diabetes. Maybe they have other chronic conditions, maybe chronic kidney disease. If you think about that just on its own self, somebody's going to end up on dialysis. They're going to have diabetes first, so the drug would be covered for that. But think about some of these other conditions like blood pressure and cholesterol and other metabolic conditions. They do have downstream effects. If you just slice the data to look at people that are inside of your population that are obese, they're going to have higher costs associated with them because they're taking more medications. They're probably going to have more complications. And so the argument in this article that the drug makers are making direct to employers is, if you help these people lose 20% of their weight, which these drugs, they have studies that show can have that outcome, you're going to reduce the number of medications. You're going to reduce their occurrences of chronic disease states. They become healthier. And then the downstream effect in subsequent years. So it's a year 1, year 2, year 3 investment. And then ideally, at year 2 and beyond, there's going to be an improvement in your population health, which is going to drive lower costs. And there is an argument for that. I mean, there really is, because we see it in the data all the time. It's, as I mentioned, obese people generally consume more healthcare and they have more chronic disease states.
Yeah, it's a sensitive topic for sure. It's hard to navigate because, on one side you think, yeah, there's going to be other good things that come from it, but then there's also potentially other things that could be worse, because it was such an extreme change so quickly. And yeah, it's one that's going to be a tough one to navigate when, if things ever fall apart. I mean, I remember all the fen commercials when I was growing up, like, and when that whole thing collapsed, and that's a very different drug and a different, way that it did things, but which found out, they found out was very bad. And so I think some people maybe feel like this is a similar repeat, but this is not the same drug at
Yeah.
all. So it's a tough one because we've put ourselves in a society where we're comfortable. We eat a lot. We don't exercise enough. I mean, there's all the different things you could do. This is a shortcut, and a lot of people will pay money for shortcuts. And when it's a drug like this, you think, well, it should just be covered by insurance.
Yeah. Which really leads us into the main topic for today, GLP-1's. The big question is to cover or not to cover. That's the question that we're getting a lot. And it's literally, Jake, a topic that comes up in every single one of our client meetings, because they're getting feedback from employees that they want these medications covered. I mentioned earlier, they come with a pretty big price tag. It's about $1,000 a month. Just, I'm going to round it average. So it's usually a little bit less, but when you round it up, it's about 1,000.
So what do you see? Are they covering it? Are the insurance companies, like in a fully insured level fund, are they covering it? Obviously, if you're self-funded, you have a little more say and with your pharmacy benefit manager, but
Yeah, there's some loopholes. There are some loopholes. So that's a great question, Jake. Let's dig into it. So, last year, it was actually started about 2 years ago. Let's just say 2022, really into 2023. We saw a huge spike with a number of our clients in their pharmacy costs, and carriers were increasing their premiums in the fully insured world to cover that, increased funding and self-funded plans to cover those costs as well. We had some that had upwards of 40% spikes in their pharmacy costs, and the main driver behind that was this issue of GLP-1s. And so, to answer your question specifically, are insurers covering these for weight loss? And in Texas, and every state's dependent because they're subject to your state Department of Insurance, but we had groups that would transition from a fully insured plan into self-funded plans where we could get more data. And what you would see is a huge number of people taking these medications. I say huge, but it could be, 10 to 20% of the population are taking these medications. But when you look at the data, you don't have a 20% occurrence of diabetes. And so that indicates to me that we've now got people taking these medications that don't have diabetes because they're not being treated for diabetes. But there's a loophole often in the prior authorization process. And so what I mean by prior authorization, for anybody watching this, when your doctor prescribes a drug and that particular drug requires approval before it can be done. So if you go in and you have an infection and your doctor prescribes an antibiotic, that's just going to get filled. Those drugs don't require a prior authorization 99% of the time. It's a everyday use drug. But when a drug has a certain cost associated with it, oftentimes the plan is going to require the doctor to submit something to the insurance company for medical validation. Jake needs this medication, and this is why. Doctors hate doing it. It's a huge burden administratively. But so what doctors were doing, the doctors are smart. They figure out the system. They have a patient that wants to take the medication. Oftentimes, the way the prior authorization process worked is if you have a diagnosis of diabetes or you're taking a medication related to diabetes, a real common one is going to be metformin. Metformin is super cheap. It's been around and highly researched for 60 or 70 years. It's been around for super long time. And you can get you can get a prescription for metformin and it's like $3 or $4. It's super cheap. And so what doctors figured out is if I prescribe you metformin, I can go in after prescribing metformin, even if you don't have diabetes, and then I could submit, hey, he's taking metformin, Jake's taking metformin, it's not working, I need to put him on Ozempic or Mounjaro, and they could get an insurance company to pay for it. And so you saw high utilization of non-diabetic of the population using it for weight loss. They're just circumventing the rules. And so what we did with a lot, and this was really interesting, I had not every one of my clients wanted to do this, but I had a big percentage of my clients that were agreeable to this is, hey, this is going to be a little disruptive for the employees, but we're going to do what I would call a hard retro PA process, prior authorization process. We're going to wipe all the prior authorizations out for GLP-1's, and we're going to require the doctors to resubmit prior authorizations in the new plan year. And we're only going to cover GLP-1's if you have a diagnosis of diabetes. So that's important to this distinction, because a lot of pharmacy benefit managers, the one thing they don't want to have is, disruption, because then the employer gets upset, the employees are upset. But in this case, because of the spike in cost, we needed to ensure that only those that were really taking it for what the plan sponsor, the employer, wanted to cover, which is diabetes, is what the drugs are being used for. And so I had a couple of employers that did this, and what we saw is a pretty notable drop in GLP-1 usage. So they've just taken an employer group that's got 20 employees. They have 15 or 20 users of GLP-1s. So say 20 GLP-1 users. We go through the hard PA process, and then about 6 months later, you look at the data, and the usage dropped from 20 to 13. And to quantify that, that's a $7,000 a month savings to the employer, because they're no longer covering a drug that is being used for an off-label use. Yeah. So, I mean, for that employer, I mean, 7,000 times 12, right? So you're looking $80,000-$90,000 savings. Not a huge needle mover, but you think about, okay, that's $80,000 or $90,000 that we've now got left in the budget to cover a big surgery or to cover some other health use. The intent of the plan wasn't to cover it for weight loss. And that's the question that we want to tackle today. But just, I think it's important for people to understand how the system can be gamed. And oftentimes, if you think about an employer who's setting a budget that wants to cover benefits, they want to cover, this is what we want to cover. We don't want to cover things unnecessarily that's outside of the intent of the plan. This is one way you catch that. And, but the bigger question that we're getting today is, should we be covering this for weight loss?
But even if it's not covered, is the demand high enough that someone's going to figure out a way to just pay out of pocket themselves if you take it out of the plan and allow it? Is it that widespread now that people are just going to do whatever it takes, even if they have to go to Mexico to get it?
Oh, yeah. The answer is yes, and the answer actually is much simpler than going to Mexico. It's much simpler than going to Mexico. I'll give you a couple of examples. Eli Lilly. So we talked about these medications. They've got they're the manufacturer of Mounjaro and Zepbound. Same drug. Mounjaro is for diabetes. Zepbound is for weight loss. They've got a website set up. It's Eli Lilly Direct, and it's specifically for people that want to buy the weight loss version of the drug Zepbound, but their insurance won't cover it. And so you can go directly to their website, and it doesn't cost $1,000 a month. Depending on the dose, it's probably it's like $450 to $600, and you can get it. Which that brings up another question: why would it be cheaper? Well, This is a reason why pharmacy benefit managers are probably pushing to cover it more, because there's rebates associated with those drugs. And depending on the contract that PBM has, they could be getting $200 to $400 a month or per fill rebate. And oftentimes when you look at rebate contracts, they're not passing the full rebate back to the employer. If you're fully insured, none of it's going back to the employer. So it's a moneymaker for the PBM. And so oftentimes your PBMs are saying you should cover these drugs. Here's your formulary. Oftentimes the formularies are designed to maximize profit for the PBM. And they don't they're not very transparent on how much money they're making with those, and are they in fact giving all that money back to the employer. In the plans that we design for our clients, 100% of those rebates, if the rebate's $400 on that drug, that $400 is coming back in the form of a payment to the employer. And so some of these plans, they generate 100, 200, 300. I mean, we've got larger employers, it can be seven figures of rebates that used to be captured by the insurance company and the pharmacy benefit manager. They're now coming back as a source of income to the plan. And that helps offset the cost of claims and those other things. Why let somebody else capture the value when you should be capturing it as an employer? And it's simple things like that. But to answer your question, that's one option for employees to pay for those medications if they want them and it's not covered by a plan. The other, which is super popular, I hear this constantly. I mean, I have employers that will set up reimbursement plans for employees that want it for weight loss, and they'll set up a MERP or an HRA to cover out-of-pocket expenses for employees that want to get it from a compounding pharmacy. So you think tirzepatide, which is Mounjaro or Zepbound, $1,000 a month if you buy it through insurance. You can go get the same medication month supply. It's about $250 from a compounding pharmacy. Now there's a lot of questions, and the drug makers will throw out, we don't know what they're actually producing in those compounding pharmacies. It could be something fake. It could be, you name it, right?
We're gonna have a guest, hopefully in the future, that owns a compounding pharmacy. I'm excited to dig into some of these
Yeah.
questions, but you're right. You
Yeah.
don't know what you're buying sometimes, but I think that goes back to, if you are a CFO or CEO or head of HR or in charge of benefits, how do you navigate this? Like, what, I don't even, I'm trying to just think like a scenario. You've got 100 employees and you just found out the reason that your renewal was so high was because of these drugs, and you're wondering what to do and the ethical thing to do and how you handle the culture around making a change on that with your employees. And it's a tough spot to be in, but it's one
Yeah.
going to come up if it hasn't yet.
Yeah. Yeah, it is. I mean, if somebody wants to use a compounding pharmacy to offer that benefit for weight loss and they want to cover it outside of the traditional medical plan, I mean, the number one thing is make sure you're partnering with a good compounding pharmacy. And I have clients that do that. Their compounding pharmacies, the ones that there's two that we work with that are here in the North Texas area, but they ship nationally overnight. And I mean, you are kind of rolling the dice a little bit. I mean, they're long-standing pharmacies. They've been around. They're not pop-up pharmacies that just started in the last couple of years just to sell this. You see that online a lot. There's advertising on television. I won't name any of the names, but you see them advertised on social media and on television. Hey, call us. We can prescribe it. We'll ship it to you. I don't know much about them. I don't know how long those pharmacies have been around, but these two pharmacies that we work with, multi-generational, they've been around. One's been around 50 years. The other's been around a little bit longer. And what I have seen just with my clients that do it, the people that are using those compounded medications, the question I ask, are they losing weight? Are they having adverse effects? Does it work? And a resounding, it's yes, yes, yes across the board. So, they're licensed pharmacies that, I mean, the reality is the drug itself is trademarked. The method, so they patent the delivery method, which is a pre-dosed injectable shot, but they don't own the chemical compound that's active. Those pharmacies can create that exact chemical compound. That's why they're there. If somebody needs a medication, it doesn't matter, you name it. I mean, there's a lot of times they can create those medications chemically, and that's what they're doing. And they're just using a different delivery instead of it coming in a pre-dosed shot where you just click a button. They're putting it into a vial and you draw it in an insulin syringe and you inject yourself with it. It's just a little bit different delivery method, and it's not the name brand, but it's like buying a generic. Somebody's getting Lipitor or Crestor for cholesterol. You go get generic rosuvastatin. Same active ingredient. It's just made by a different manufacturer. So
This is probably a good way we could add more value, is like making a list of all of these, or at least some resources, so that if you are in charge of your health plan, understanding it, I mean, you got to get your claims data as number one. If you don't have that, like, you've got to get there so you know what your employees are using. But staying on
mhm.
top of these is definitely not going to be your main focus. So how could you, be aware of the next trend or the next drug, the next thing that could be causing that renewal for the next year to be such a unhappy moment because you weren't aware of this.
Yeah, well, think about this, Jake, for just a second. Um, if you're an employer and you give an insurance company $1 million a year for health insurance, I'm just using round numbers here. The insurance company comes back and says, "Hey, employer, we spent $1.2 million for your healthcare for your employees. We're raising your premiums." Usually, the first question anybody asks, "Well, what did you buy and how much did you pay? What did you buy and how much did you pay for it?" And you know what the insurance companies say? We're not going to share that with you. It's not your business. And I'm an employer. I run a health plan, and it's expensive. We spend a couple $1 million a year on healthcare for our employees. And when I look at it, I want to know, well, if I'm giving you this money, it's a big sum of money. I want to know what you're buying and how much you're paying for it, because for all I know, you're going out and buying Ford pickups, but you're paying a Ferrari price. You're paying for Ferraris and you're getting Ford pickups. And so that's probably the most common occurrence that we see, is that the insurance companies don't spend the money the way that you want, and they won't show it to you, which is, to your point, why having access to data is so important, because you can hold somebody accountable with the data.
And what regulations? I mean, we can. This is probably another topic, but around the data itself, who gets access and how detailed is it, and as far as privacy and all those different regulations around that.
Yeah. Are you asking about in a self-insured plan?
Yeah, when you do get the data, how do you, like, how much of that is really clear of where those charges are coming from? And I guess that's a probably another topic. But from a
Oh,
fiduciary
oh,
standpoint, from a regulator standpoint, there's a lot going on there when you get the data and you're saying, all right, we got too many people doing Ozempic. What are we going to do about it? And then you can't go out and tell the employees, hey, we're going to cut Ozempic out now. Go get it on your own because we're not going to cover it. And it just causes a really interesting, like,
yeah.
stressful situation.
Yeah. It's not as scary as you think. It's not as scary as you think. So there's a lot of um, regulation around how data is used and shared. And so you're talking about PHI, personal health information, and you're talking about HIPAA security. And so the number one thing is making sure you have proper protocols in place. So somebody at the company, if there's a HIPAA certified officer that has privilege to access that information, some of our clients, the majority of them, don't want to know names. And so therefore any reporting and information is de-identified. So you can run these reports that completely remove any sort of personal identifying information. It will just be in, an encrypted member number. Hey, that claimant number one, claimant number two, here's what the condition is, here's where they're getting care. But when you talk about how specific the data gets, I mean, any one of my plans that I set up, if I need to know where did this person go, what time did they walk in, what specifically was done, you can get the medical notes. Like, what did the doctor write? And the reason why that's important, Jake, and we're getting a little bit off topic, but when you have that sort of data, this is where it's super impactful for an employer. And I'll give you a really common example, super common example that's a cost driver for employers. An employee will go into an emergency room because they need stitches. They got cut. It's a Sunday afternoon. Urgent care may not be open. I've got a bleeding wound. I've got to get treated. I go to the ER to get it sewn up. And so based on the hospitals are smart. They know the more urgent they mark that claim, what's the level of care that's needed, level one, or not level 1, but I'm saying, like, using an example here, like a basic, I go in, I just have a cut on my arm, I just need to get it sewn up. It's not a huge, um, emergency. I'm not at risk of death. But oftentimes what you'll see hospitals do is they up the urgency of the claim that this person needed a higher level of care. It was a truly emergent, it was a life or death situation, and as they upcode it, it make because it's more urgent, more severe, they're able to get a higher reimbursement from the insurance company, and so you see gamification in that. And there are ways to ferret that out in a health plan to ensure that you're paying the appropriate cost, because what should be maybe $1,000 episode of care might be billed and paid at 3 or 4,000. So you end up paying 3 or 4 times what you should have paid. Not a huge needle mover on one particular claim, but when it's systemic and it happens across a larger group of people, it ends up to real dollars at the end of the day. And whatever the insurance company is going to pay, they're going to collect from you in premium the following year. And so it's important to make sure that we pay appropriate prices for the healthcare that our employees are consuming. And so all
Going
that
back
to
to
say,
your example, sorry, your example with the $1 million, you spent 1.2. We're going to raise your premium. This is something I dug into with a client recently. Was what's the ratio of admin costs to claims, right? Do you actually know what portion of that? Fully insured, they don't have to tell you. So do you have an understanding of what is really being covered for the care versus what they're charging you to keep track of everything and do it all?
yeah, yeah, I think that's a valid point. It just goes back to the question of data. Do you have enough information to make an educated decision? And is your broker advisor able to distill it to help you understand where you're spending money? And I think that's the biggest thing for employers to take away. You know, we talked about doing the same thing, expecting a different result. And if you're just taking a fully insured renewal, or you shop it, say you're with United and you go to Blue Cross or you go to Cigna, that's the most common solution that we see in the market. We're just going to shop your plan. But if you look at the business model of all of those big insurance companies, they're all very similar. They're all vertically integrated. They're all monetizing certain types of claims. And in a fully insured program, they're not giving you access to the data that you really need to make an actionable, good actionable decision of how your dollars are being spent. And I think there's a misconception with employers that burden of analyzing the data and making the decision falls on them. And that's really the role of having, well, I mean, what do you have a broker for if that's the case? And at the end of the day, it really is the broker advisor that should do all of the heavy lifting, do all of the analysis, put all of the strategy together, present it to an employer in a very concise way. This is where your money is being spent today. It's being overspent. These are the 3 things we need to do to solve it. I'm going to recommend that you do this, this, and this, and we're going to measure it. Let's test it. Let's measure it. And if it's working, great. If it's not, we'll adjust one of the 3 variables. But a good advisor is going to put a plan in that works. It's going to work. If they're underwriting it and they're doing their analysis correctly. And the way you ferret that out, and this is, part of the checklist that I give employers, is you need to not only look at case studies, you need to talk to their clients. So I should be able to give a client, name an industry. I should be able to give you somebody that's either in that industry or a very similar industry that has similar dynamics with the employee population base. And you should be able to talk to that employer and say, CFO to CFO, owner to owner, HR to HR, ask them about what they did it work, and would they recommend that advisor to do it for them? Because that's how you're going to ferret out good advisors from bad advisors. Have they done this before? I'll tell you this. I had a surgery a few years ago, and one of the first questions I asked was, how many times have you done this? And the surgeon was offended, and I could see a look on his face. I'm like, look, man, I just want to make sure that I'm not your first one. I want to know how many times that you've done this and what's the success rate of this. Now, I couldn't talk to his patients, but if the guy told me he had only done this 3 or 4 times, I'm going to be really concerned because he probably doesn't have the experience. But he said, I do this probably 20 times a month, and I've been doing it for 10 years. Okay. you got the requisite experience. You've seen just about everything that we're going to see when you cut me open. Okay, cool. I'm good with that. And you see this occurrence happening right now where there's a lot of brokers that are talking about solutions, but they haven't actually done it. And I don't know if I'm an employer, I want to be somebody's guinea pig.
Right. They talk about it and they use it in a way to get you to kind of tiptoe towards that direction, but not necessarily go all the way to partially self funded. Right.
Yeah.
It's a common trend, and they kind of protect themselves because they brought it up, but they're not necessarily willing to put the work in to get you there. And I mean, I
Yeah.
remember early in my career, because I was with a benefits firm doing the 401k part, and I would go in with brokers and the renewals, we'd sit down and we just go through the spreadsheet, this carrier, this carrier, this carrier. And I was like, it always baffled me. I'm like, what? This seems like we're just looking at, different cell phone plans. Like, what are we actually doing here? And so it always kind of bothered me for many years. And now, like, it makes so much more sense to dig into it the way that, that we do, and the way that we're doing the work behind the scenes. But I get it. It's harder. There's a lot more we have to do. And you typically make the same or less, and you get to that consulting kind of relationship where it's not our pay, our compensation for the work we do is not tied to you having to pay more every year. Like, that's the big thing that has to be disconnected initially, I think.
Yeah. I think that, so you said it, and I think it's important to clarify it. It's a lot more work for brokers to do this. It's not a lot more work or lift for employers, because the broker's doing all the work, putting the plans together, putting the recommendations, doing the strategy, bringing it on a platter. Mr. Employer, here it is. Here's what it looks like. Here's how you do it. To your other point, yeah, you're probably going to make less money as a broker doing it, because you're cutting out this misaligned incentive. The carriers are paying brokerages big bonuses to keep you in the standard plans, to keep you in a really traditional plan where they get to monetize it. That's where they get the money to pay the bonuses. They're monetizing, harvesting those claims, making profit from that, and then they reward the brokers for keeping them there. And they're paying the piper to keep the music playing. Meanwhile, employers are paying more, employees are paying more. The the real consumers, the real buyers of healthcare are being punished for this, while everybody else is making money paying for their country club memberships and their vacations and their private jets and whatever it is that they're buying. And that's systemically, that's what we see. But it's the advice that I would give if there's an advisor watching this, it's thinking about, man, I really think I should be doing this, but I'm not quite sure how or why I would do that. Think about this from a business strategy standpoint. And this is what I argue with as I teach around the country, other advisors how to do this is, if you solve your client's biggest problem, think about this for a second, Jake. If you solve the client's problem, what's the likelihood you're going to lose that client? If the client knows you're working in their best interest.
Yeah, because you're aligned with them. You're not just selling them something, right? You're actually trying to understand their business, and that's where, you look at the largest employers in the world, that like Walmart and Amazon. Walmart's like over 2.5 million people. They're number one. They're in the healthcare business. They're buying healthcare for 2.5 million people. They're paying for it. It's part of the compensation, and so we think of Walmart as just a retail store, but no, like that's a that's their business, right? And so when you take that same mindset and you apply it to whatever employer down the street with 100 people, it kind of blows their mind because they're not used to thinking that way, and so it's a disruptor. But they see you as a partner versus a salesperson. That's got to happen fast.
Yeah.
Yeah.
And I'll go back to the point that I made earlier. You talked about Walmart being in the healthcare business because they have so many employees. Well, Walmart's a lot larger organization. They've got higher revenues than a 100 Life Group down the road or a 500 Life Group down the road. But if you put it into relative terms, as a percentage of the budget, it's a big portion of their budget. And for a 100 to 500 Life employee count group, it's a big part of their budget too. But they're not managing it like a division of their business. And that's really where we're seeing this momentum of employers that say, we've had enough. We need to manage this like a business unit. We need to hold somebody accountable for the income coming in and the expenses going out. We need a better way to manage it. And so I think that point can't be more emphasized.
Which leads into our next show. I think it's a good point. So this show, I mean, GLP-1's hot topic. Hopefully that gave you some sense of what you should do, some questions you should ask, maybe the mindset you should have as a business owner when it comes to this topic. When it comes up, you've got to get the data. Which our next show we're going to dig into: can you get that level funded or even fully insured experience with a partially self-funded? When we say partially, meaning you're going to buy stop loss insurance and kind of limit your risk there. Fully self-funded is not very likely with unless you're just huge like Walmart, because you're
Mm-hmm.
going to have that coverage. I'd love to do another show, even a deeper dive into the stop loss world, but understanding what you have to do in the contract of the stop loss to help prevent, a month of a bunch of claims you weren't expecting that were not going to hit the stop loss. I mean, there's all sorts of things that come up when you start to explore that. We're going to dig into those and get more specific on what contract details you need to know, and how you can tell if your broker's experienced or not.
Yeah, one thing before we close out, I do want to wrap up with just actionable insight on whether or not employers should cover GLP-1s or not. And I'll hit these really quick. The argument against covering GLP-1s, which a lot of employer for weight loss, I mean, everybody, if you've got a major insurance company or a major PBM, they're covered for diabetes. The question is, do we cover it for weight loss? And the majority, that article from the Wall Street Journal talked about 40%-ish of large employers are covering it for weight loss. When you move downstream into small and mid-sized employers, very few are. I would say the number's probably 10%, maybe 20%. It's probably smaller than that, but a much smaller percentage of the population of employers in the small to mid-sized market are covering GLP-1s for weight loss. And the biggest reason against covering for weight loss is the initial cost. It's $1,000 a month. If you get 10 people to take them for weight loss, you're going to spend $120,000 a year on these drugs for weight loss. Now, that's the number one argument against it. Now let's talk about the arguments why an employer might want to cover these drugs for weight loss in their employer sponsored plans. We talked about the cost. The trade-off would be like, okay, what's the ROI? How can I measure? Is it appropriate? And how would I measure success if we decided to do it? The first thing you want to look at is what percentage of your population would be eligible to take that medication for weight loss. I would highly advise against covering it blanketly for weight loss, just in general, because you end up with somebody that just really needs to lose 5 or 10 pounds. They're not obese. They don't really have, it's just, I want to look better because summer's coming up and you're going to get some use of the drug for that. I mean, look, diet and exercise is probably your best bet to accomplish that. Um, so for my employers that do cover it, they want a diagnosis of obesity. And I have a couple that say they won't cover it unless somebody's morbidly obese. So if you're obese or morbidly obese, then it would be covered for weight loss. That would be an indication they would cover one of these medications under that scenario. So yeah, there's medical. Yeah, I mean, you can Google it, and I don't want to steer you wrong, but maybe obese is 30 pounds overweight, and morbidly obese is 50 or 80 pounds overweight. I don't know the exact parameters, but there's medical guidelines established, standardization to define somebody as obese or morbidly obese, and BMI comes into that equation as well. If you've got a BMI over a certain threshold, so you have to have a way you have to have a standard to be able to consistently apply it. It can't be a judgment call of, well, I mean, Jake, you look a little heavier today. I think you might be obese. And anybody that looks at Jake is not going to consider you obese, but you might look at yourself and say, man, swimsuit season's coming up. I probably need to lose 5 or 10 pounds. Doc prescribed this medication. Well, this is where the prior authorization comes in. They're going to have to send it to the administrator, to the insurance company to approve it. And the first thing the administrator is going to look at is, is Jake obese or morbidly obese? No, he's not. He just needs to lose 5 pounds. So
Would
won't
you
get
be able
covered.
to make that where you have to define it as that for them to get covered? You couldn't do that in a
100%.
fully insured or level funded plan. That have to be
No, they
partially
don't.
self funded.
That's right. That's right. So if you're fully insured, level funded, I mean, you don't with a carrier. Yeah, if you're level funded with a carrier. Now, I think that's an important topic that we need to talk about is what's the difference between level funding with a carrier, and that's probably the next show that we'll do, we can talk about when you self-fund a plan, what are your options, but there's a big difference between level funding with a carrier, so Cigna, United Health, Aetna, Blue Cross, versus using an independent administrator, getting stop loss and level funding that way. There's a highly customizable difference between the two. So I'm just going to talk about traditional level funding and fully insured with a carrier. You don't get to pick. It's whatever that carrier has designed in their plan. But to answer your question, for partially self-funded employers, if you want to cover it for weight loss, you typically are going to put a standard that has to be in place. It's either obese as defined by the medical guidelines or morbidly obese as defined by the medical guidelines. So there's clear distinction. Does this person meet the qualification of obese or morbidly obese? Yes or no? Yes or no, the drug is covered. So year one, there's going to be a big cost. As soon as people start taking the medication, you're going to have an increase in your cost. The argument to cover these medications for weight loss is, what is the downstream effect? As these people lose weight, they become metabolically healthier. Maybe they're able to come off of their blood pressure medication. Maybe they're able to stop taking their cholesterol medication. Maybe they're able to get off these other medications, which can prevent other downstream costs like heart attack or stroke or other chronic illness, which reduces those catastrophic claims or increased claims costs that those people might incur in subsequent years. As your population becomes healthier, you should see that occurrence, and that's what you'd look at. So you'd start with, what percent of my population is, this is the gold standard, Jake. This is the gold standard here, because if you're fully insured, you can't do this. But if you're already partially self-funded and you have the data, first thing I want to do is I want to look back over the last 2 to 3 years. What percent of my population is obese or morbidly obese? Okay. Now that I've sliced that piece of data out, it's going to be a pie like that. Okay. Now I'm going to look at just that population. What sort of medical claims do they have versus the rest of my population? And I'm going to look at medications that they're taking, surgeries that they're having, hospitalizations. What's the total cost of that? And I'm just going to make up numbers here. This is just an example, but I can look back, and in any given year, that population is incurring $500,000 in these other claims of medication, surgeries, emergency rooms, hospitalizations, all that. Okay. All right. So if I'm going to pay for that population to take these weight loss drugs, what is that going to cost? It's going to cost $100,000 a year to cover those drugs for weight loss. Okay. So what sort of impact can I have on this average $500,000 of claims? What should I expect in year 2 and year 3 as a reduction? And that's a little bit harder to quantify because we don't know necessarily, but there are some standards that you can use or benchmarks to say, okay, Jake, if I'm able to reduce your chronic claims related to obesity by 50%, so I could take it from 500,000 to 250 in year 3, if that's the outcome, is that desirable or not? And that's where an employer has to make the call, and you have to measure it. So you got to look at it. What is the data telling us as we get into year 2 and year 3? Are we seeing a reduction in those chronic claims and utilization? But there's a third factor in this that it's true. I don't like using it, but I call it the fuzzy factor. And anybody that's heard me talk about wellness plans, there's fuzzy math that's used, and they talk about happiness, healthiness, productivity. It's a yeah, it's a real thing. It's a real thing. And um, I say this as somebody, when I played football in college, I weighed about 275 pounds. I'm about 200 pounds today. I will tell you this, as somebody that lost 75 pounds, I feel like a completely different person. I feel healthier. I have more energy. Um, I'm taking less medications because I was on a lot of medications when I was at that weight. I'm just generally a healthy, more productive person. So there is validity in that argument. How does somebody show up to work when they've lost 50 or 60 pounds? They're going to have more energy. They're probably going to feel better about themselves. There's a psychological effect of weight loss. You look at anybody who's lost a bunch of weight, whether through GLP-1s or diet and exercise, they've got a little extra pep in their step. They feel better about themselves, and they have more confidence in themselves. They're probably going to be with more energy, more productive at work. So there's that other aspect that an employer would probably need to take into the equation, and because wellness is a big is a big thing for a lot of employers. We want our employees to be healthy because they're more productive. And so I think there's an added benefit that needs to be added to that equation to help determine whether or not weight loss drugs should be covered. I'll just tell you my stance on it. Historically, over the last 2 to 3 years, I've been against covering it for weight loss, but I think there is an argument, if done right, to actually cover this in certain situations. Depends on the population. I'll just throw out another as I'm ranting here. And I'll shut up. There's a number of employers that we work with that are in high turnover industries. You think about manufacturing, auto dealerships, um, a lot of construction, high turnover industries. Uh, Look, those employees, if you've got a 40% turnover in 3 years, that means you're going to turn over your entire workforce except for your leadership. Uh, you're not, those employees won't be there for the employer to reap the benefit of a healthier employee in those cases. So that probably skews heavily against covering it for weight loss. But if you've got a bank, a law firm, an engineering firm, very low turnover, 1 to 3%, an insurance brokerage, you got 1 to 3% turnover, those employees are going to be with you. Maybe it makes sense to cover it in those situations. I think you got to start foundationally. Do we even have the population that needs it? And then if we do, what's our turnover? And then we need to look at the costs and the benefits of, and do that analysis at that point. There's not a clear black and white answer. Do we cover it or do we not? It's actually a really nuanced conversation that needs to be had with somebody that has the data to help you understand what is the true impact. So I'll end with that.
Well, and it honestly goes right in line with the idea that your health insurance, your benefit strategy needs to change with your business strategy. It has to be intertwined with it. I tell people this all the time. It's like you set up. It's not a set it and forget it and just keep renewing every year and take the whatever increase was and move on. It's not a cost of doing business. It's an investment in the business to help it strategically accomplish the bigger goal. And so understanding what things are going on behind the scenes so you know how to make it effective is going to change. But it needs to be, I love Gary Vaynerchuk's terminology on this with clouds and dirt. It's like you got to see and think bigger than just a year, but you've got to get in and do the tactical stuff every year. Doesn't mean you're just doing one or the other. You got to think 3-5 years out. You got to do the stuff right now. There's no
Yeah.
easy time. You've got to just jump in and do it. Waiting later might not be the right move, or it might. It just
Well,
depends on what you're trying to accomplish, right?
yeah.
So it's a strategic decision.
Or it might not even be an option next year because your claims risk does change, which skews the numbers, which can mean the difference between viability or non-viability. The last thing I would just kind of throw out there, you hit on this earlier, diet and exercise as an alternative GLP-1s, which is the natural way to do this, right? Um, the So it's harder. It requires discipline. It requires knowledge, education. What do I eat? How do I train? What do I do? And that's often harder to do. Even for people that want to lose weight, struggle with losing weight. And I'm going to say this, and I'm going to sound like a shill for the pharmacy industry to cover these medications, but I'm not. But what I would say though is, if you think about, just look around your workforce, walk down the halls, and see people. We're going into New Year's right now. Everybody's going to have a resolution. Not everybody, but a huge percentage of our population, because obesity and being overweight is so prevalent in our society. How many people do you think are going to set a New Year's resolution to want to lose weight? 8 out of 10 people, 7 out of 10 people, even people that are not really overweight, they want to lose 5 pounds or 10 pounds, but it's super hard. And usually 6 weeks into the new year, people have given up that resolution. Why? Because it's so hard. And so, right. And so there's a lot of things that are probably going to be coming down the pipe, especially after the election and RFK, taking a leadership role in the administration, wanting to make America healthy again. That's a very hard problem to tackle. But if there's a way to help employees to become healthier, I mean, I had a doctor. I'll tell you this story real quick. About 10 years ago, I had a doctor who I had high cholesterol, and he just wanted to throw statins at me. He's like, "Hey, just take these statins." I was like, "Well, hold on a second. I want to do something before I take these. Like, how about I lose some weight?" And he's like, "Everybody says that they want to do it. Everybody says that they're going to do it, but nobody actually does. Just fill it. Just take the medicine." And so that's always stuck with me, that even when people want to do it, it's still super hard. And if there's a way to help people do it, and you can do it in a cost effective way that generates an ROI, it might be worth doing. It might actually be worth doing. The jury's out. I have clients that are doing it now, and so I have a good data set to be able to measure. And my opinion, I leave myself open to change my mind, because with data and time, you've got to be open minded. You can't be dogmatic in a position, because you just entrench yourself, and you're going to look for data to support your position. I want to be open minded about it. If I see an improvement in health and claims in some of these employers, that's going to change my mind. I really want to see what happens. That's the argument of big pharma. This is going to improve the health of a population. They're going to incur less in claims downstream. If I see that happen, and it's the right employer, as we discussed, yeah, I think it's something that we should definitely evaluate. So I'll end with that for real this time.
Perfect. I think that was a great way to cover this. It's a sensitive topic, but it's, I'm sure, one that'll possibly come up over Thanksgiving or the holidays with your family, and it's one that you got to be careful about what you say and think, and opinions sometimes need to be soft and changed, and I think that's where I've tried to stay as well. I'm of the mindset I can't come to work if I haven't worked out. I've made it such a part of my life, and now I'm getting my kids into it. I go with my 15-year-old in the morning, and then I come back. He goes to middle school. I grab my 12-year-old, and we head out, and we're doing super lightweight, really good form. I'm just trying to really get them, starting that habit young of
Yeah.
of exercise and eating well, and just, we have the opposite problem. We can't put weight on. They both play football and they're little sticks. So we're trying we're trying to put weight on, which is a different battle we're having, just because of our genetics. But it's not, everyone has things and everyone has goals, and I think these the drugs help us through different problems at different times in our life, and it's oftentimes leads back to, what does our insurance cover, whether we're going to do it or not.
Yeah. Well, there's ways to cover it outside of insurance and do it in a cost effective way, which leads me to my another point. It makes me wonder. It makes me wonder, should you and I both try GLP-1 just to see what it's about?
I There's a bunch of I mean, it's a hot topic. My wife, we've talked a lot about this, and when I told her we were going to talk about this today, she's like, "You better be careful. Like, there's people get offended really quick, and there's a lot of posts on like TikTok and Instagram, and it's funny to read the comments, where somebody's talking about all the other, aside, even above and beyond just losing weight, just the mental clarity and like all this, and the comments are just, they're hilarious. We should probably read some on another show of just the general like comments you see about, oh, this is just the most amazing thing ever. But you're right. Like, I don't know. I've never tried it. I don't know what it would do. But it's interesting.
Maybe we should try it. I don't know. Um, we should try it for a short time and just see what it does. I don't know. I'm a big believer on personal experience.
Yeah.
I don't know if you can lose any more weight. You're already
I don't
ripped.
know that I want to do. Yeah, I'm trying to do the opposite right now.
Yeah.
What's funny is, like, I grew up, a runner, and like I went all through college just same weight for the next like 10, 15 years, like, really, really thin. I always was kind of exercising, but I never really understood weightlifting. And so I've kind of come full spectrum, where I thought running was the only way, you stayed healthy, and completely backed off. And now I rarely run. I can still go out and hang. I went running with a friend on Saturday, so I can do it. But I realized there's, for me, long-term health benefits. I've seen some more negative with running a lot than positive. And so things change. Like, right
Yeah.
now, this might be a good fit for somebody. Might end up being a horrible thing. We don't know.
Dro- well, drop a comment. Drop a comment if you think Jake and I should try GLP-1 just to be able to provide personal feedback, hands-on experience. Drop a comment if you think we should do that.
Okay, that'll be interesting. We'll see what we get. Oh, this is good. Yeah. Any other comments? Also, other topics, things you're hearing. We have a huge list of things that we hear all the time out visiting people. But we're going to continue making this show and have fun, showing people what we do behind the scenes, because it's a very hidden industry. And all throughout the show today, I kept thinking of a couple different Office episodes, like the weight loss episode, the healthcare episode. Like there's a lot of impact that these things have in your family, and that's what drives me to be here. Is like I got 5 kids, and I got parents. I've got people that are impacted by the decisions of their employers, and it's
Mm-hmm.
it's a big deal, and it's something that motivates us to keep fighting through and looking for the best fit and the best solutions, and to be there and put the work in. And that's more motivating to me than than just the payday. It's
Yeah.
important, but it's a
Great point to end on there.
all right. Till next time, we'll dig into level and self funding a little bit more, and not try to repeat things. We'll try to get into the real nitty gritty stuff.
Yeah, let us know. Send us a note. Drop a comment if there's a particular topic or question that you have that you want us to drill deep on, and we'd be happy to cover it.